We live in a world where all the information in the world is at our fingertips, and sometimes it's absolutely paralyzing. And when you start getting down to the granular of weight loss intervention and weight loss drugs and pharmaceuticals, I really like to leave it to the experts. So I've got Dr. Kyle Gillett here, board certified family medicine physician as well as obesity medicine physician. Guy is a wizard when it comes down to this stuff. So first of all, thanks for hopping on.
Thank you. My pleasure.
Diving right in, we're going to talk about the 5 most popular weight loss drugs that are being used presently here as of 2023. So I'll let you take it away. What's number 1? You have to check out Boncharge's infrared sauna blanket after this video. Not a lot of people have room to put a sauna in. It's kind of a pain in the butt. I love having my sauna, but I had to run a continuous circuit for it. I had to run a dedicated electrical circuit. That costs money, that takes time, that takes space. A nice infrared sauna blanket is totally portable, and this Boncharge one has very low EMF. In fact, they were kind of surveying around, they found it's the lowest EMF on the market, but also it gets up to 176 degrees, and since you're laying inside of a blanket, you're right next, really close to the infrared light, which means that you're getting a bigger effect than if you were further proximity in a standing infrared sauna, like a regular sitting one. I think the best part about it is the fact that you can travel with it. You may not want to bring it on a plane, but if you're going on a road trip or something like that, it's easy to pack in your car. It fits in something, a couple feet, it just kind of like rolls together. But you get all the benefits of a sauna. You get that better recovery, you get that better sleep that a lot of times comes with sauna, you get those heat shock protein effects. So I definitely recommend, so there's a special link and a code down below that'll save you some cashola if you want to try this one out. Definitely recommend. I've tried a lot of them, and a lot of them are flimsy and cumbersome. I love the quality of this Boncharge one. It's easy to open up and scrub clean if you got really sweaty in it too, so it's not nasty. That's what I really like about it. So the link down below, already a great price, plus if you use that special code, you can save even more. So check out Boncharge's infrared blanket down below in the description.
All right, let's talk about semaglutide first, again, briefly. This is a GLP-1 receptor agonist. There's a shortage of it because it's so popular, so it probably deserves the number 1 spot. And it's an incretin, so there's a lot of mechanisms other than just appetite suppression. It's an insulin sensitizer, it slows gut transit, it also helps your pancreas work better. So there's a lot of different mechanisms. There is also risks, of course, for example, buildup of like bile, cholestasis, estrogen, and thyroid carcinoma risk if you happen to be someone who's at risk of that. We don't really know how concerning that risk is, but potentially it is a risk. But that's semaglutide. I guess we could just name off all 5 right now and then talk about them. So,
perfect.
Number 2, I'd say is Metformin. So, of course, very old school drug. It is an insulin sensitizer as well. It also has multiple mechanisms of action. Its best application for weight loss is in type 2 diabetics. And also sometimes in type 1 diabetics as well. It is not without risks. We could talk about it for hours, but it is certainly very helpful intervention even for losing body fat in some individuals, especially individuals with very high weight, high lean body mass, and high body fat. And number 3, I suppose we could consider bupropion, and number 4, naltrexone. Those kind of go together. There's a combo pill with both bupropion and naltrexone. That is a dopamine reuptake inhibitor plus an opioid receptor antagonist. So these do work on appetite. They work a lot in the hypothalamus. It's also dopaminergic, so it has to do with like reward center. A great candidate for something like this would be an individual that could benefit from bupropion otherwise, perhaps for nicotine cessation, perhaps for like its mood or positive mental effects, nootropic effects. A lot of people with ADHD are put on this medication as well. And then people who eat a lot at night. So night eating syndrome, sleep eating syndrome are more rare. But in general, they benefit more from like the CNS effects of these weight loss medications. They can also help regulate inflammation in the gut, specifically LDN. So it binds the same receptor as things like gluten or casein or even kratom, except it does the opposite thing of those 3. And then I guess we have 1 more, maybe 2 more. We could put Phentermine on it, a stimulant that used to be used pretty often. Mm-hmm. They now have it in a combination of something called topiramate. This is not as common, but there are some people who are particularly good candidates for it. People who have epilepsy or a history of seizure use, because it can decrease the chance of that. People who have lots of migraines, You don't want to use this in people with kidney stone history. In addition, another good candidate for it could be people who are addicted to pop. It can make carbonated beverages taste terrible. So if someone's having trouble with zero liquid calorie diet or drinking a lot of, especially like full calorie sodas, they could be a good candidate.
Gotcha. Well, let's jump into it. So we kind of covered GLP-1 a little bit, and we have a full video breakdown on that. So we'll spare the time on that. If you want to watch that, there's I'll link down to it in the description. But next up was going to be metformin. Now, interestingly, so I thought metformin was really only going to be used in people that were having issues modulating glucose and dealing with diabetes and insulin resistance. You're telling me that it's actually being used as a weight loss drug. That's news to me.
Yeah, so metformin is extremely interesting because it is going to have multiple mechanisms of potential benefit. For example, if someone has an extremely low SHBG, sex hormone binding globulin, it's the protein that binds androgens and estrogens, metformin can help bring this up. If someone has a normal SHBG, it likely won't affect it at all. But if it's very low, it certainly can raise it. And this can help balance the androgen to estrogen ratio, especially in individuals that have like effects of hyperandrogenism downstream to the androgen receptor. Not to get too specific into that, we can some other time, but essentially if they need that hormonal effect of an increased SHBG, it can be a beneficial intervention. In addition, it can help increase the binding peptides that bind IGF-1, which is insulin-like growth factor 1. So if there's excess growth hormone, for example, in type 1 diabetics, or excess IGF-1 in some people with insulin resistance, then it can help balance out these risks, and it may, or it is theoretically going to be an anti-proliferative agent. So it could help prevent tumor growth in that population. As far as its weight loss effect, it is an insulin sensitizer. They renamed the receptors. They used to be called GLUT2 and GLUT4. Now they have different names of them, solute co-transporter something, so that, because it's not just a glucose transporter. Yeah. But anyway, for the solute co-transporters, both in the liver and in the periphery, for example, in like somatic muscle, then they're going to help with the uptake of glucose given the same level of insulin. So people with very high fasting insulins can be a good candidate for this, because you're thinking about the trade-offs of metformin. Well, if you give it to someone who's metabolically healthy, which is likely between about 6 and 15% of the population in this country, then it will likely have no benefit and may even have some detriments, given that it affects some of the downstream pathways from not only the androgen receptor, but also different pathways that lead to mTOR activation. However, if you're thinking about this medication for weight loss, then presumably you're probably not metabolically healthy, likely have a high body fat percentage, and it can also be used for people that are coming off semaglutide that still need something with like less confounding variables to help as an insulin sensitizer.
That makes perfect sense. So if someone has chronically high levels of circulating insulin, and they're also dealing with high levels of body fat, I mean, it's kind of go hand in hand. So you start controlling one, you can hopefully control the other. I mean, and for those that are watching that maybe don't have a little bit of background, I mean, if insulin is consistently circulating, that is going to inhibit the action of hormone-sensitive lipase. It's going to inhibit what's called lipolysis. So essentially, the actual mobilization of fats, the actual snipping of a fatty acid off of a triglycerol to be able to be utilized for fuel. In other words, in a very colloquial sense, it really can inhibit fat loss, especially if you already have a lot of body fat on hand. So by potentially improving sensitivity, you might be able to sort of disrupt this a little bit. Mm-hmm. Yeah.
And there's definitely a benefit of less glycosylated proteins, whether it's hemoglobin or albumin or fructosamine, when you have nutrients, whether it is triglycerides or glucose inside the cell. And again, triglycerides is glycerol backbone with 3 fatty acids, kind of your main source of fat in the blood. And then you have your glucose, which is kind of the main source of carb in the blood, if you will. Metformin will help with cellular intake of both of those things. So think of it as like your combined pool of triglycerides fasting plus glucose fasting, or I suppose if you're a keto diet, or maybe blood ketones as well. Mm-hmm. But basically a pool of those things, and then if it is on the higher end, better candidate for something like metformin or berberine. I also posted a lot of info on my Instagram about both metformin and berberine, just because there's so many nuances, and we probably both get this question all the time.
Yeah, definitely interesting. And I'll touch on one thing that was very important that you mentioned. I think people forget the fact that high circulating amounts of lipids are a problem too. And the reason that this has become an area of confusion is because you have the low carb community. I'm probably guilty of confusing people on this too, but you have the low carb community and you think, okay, fats in the bloodstream are good. This is what we want because it means we're going to burn them. No, it doesn't necessarily mean that. In fact, when those are circulating, that is a problem too, and is usually an issue that you see in diabetics or insulin resistant people. So just important to note.
I like to check a HOMA-IR, which is a ratio of fasting insulin to fasting glucose, and also an LP-IR, or an NMR lipoprofile, which is 6 different markers, including triglycerides and particle sizes. And between the two of them, you can estimate your insulin resistance due to carbs and insulin resistance due to fats.
Yeah, that's a very important thing. Okay, let's touch on that for just a second. So insulin resistance can still be caused by excess fats circulating as well, correct? Mm-hmm. Now, this mechanism is it just because fats are sort of impeding the action upon the insulin receptor, or I'm assuming there's multiple different ways, but I've seen research that, okay, especially in overnutrition, when people are eating a lot, like excess consumption of saturated fats can be almost as bad, if not equally as bad, as excess amounts of sugar in the sake of overnutrition. Mm-hmm. Are they working upon the same pathway?
There are similar tangential pathways. So think about it as a dual fuel vehicle. You have maybe compressed natural gas and you have gasoline both. So you can use both of these energy substrates for the cell, but if you're putting fuel in the car, at some point you're just putting so much fuel in that it will either overflow or just be in a higher level than you would want in the car. So for fat specifically, there's a couple different ways that you transport fats around. VLDL is one of them. VLDL is one of the ways that you carry around fats that are endogenously synthesized in your body. And then chylomicrons, which is one way that you carry around fats or like lipid-based particles that come from the diet. So a lot of that is just due to genetics. For example, if you have an ApoE2, ApoE is apolipoprotein E. There's a couple different like SNPs that you can have, but basically you get one from your mother, one from your father. You can have 2, 3, and 4. So you can be a 4-4. Chris Hemsworth in Limitless was famously a 4-4. So that's your Alzheimer's risk. If you're a 2-2, then that can carry a risk of what we call like familial hypertriglyceridemia, or it can be so high, like in the thousands, that it's even a risk of pancreatitis, inflammation of the pancreas. So a lot of it's just genetic, and it's determined by your body's ability to process both fats that are eaten and endogenously synthesized ones.
Interesting. And then there's sort of another layer with the, have you heard of metabolic gridlock before, sort of at a mitochondrial level? So in the case of overnutrition in one particular setting, a lot of this is still rodent model stuff, but it's very interesting. Or essentially if you're overfeeding at carbs and fats at once, you do reach a point, especially in people that are intermittent fasting, where they're maybe trying to load like 2,000 or 3,000 calories with one meal, doing one meal a day, where essentially the uptake of fuel substrates really it gets confusing. The body's, it's call it metabolic gridlock, where you can only take up so much at one particular point in time and actually utilize it. And usually it leads to kind of an inflammatory cascade that happens further on down the line. But anyway, that's enough of a tangent. So moving on to number 3. Okay, we've got semaglutide, GLP-1, we've got metformin, and what's number 3?
Number 3 was low-dose naltrexone, and number 4 is bupropion. But one company puts them together into the same drug. So, and the brand name of that drug is Contrave. Bupropion, also known as Wellbutrin, has been used for quite some time for not fat loss or obesity, but it was used for many things that are like cravings or addiction. For example, cravings for nicotine. It is a dopamine receptor reuptake. It's a selective dopamine receptor uptake inhibitor. So you're going to reuptake less of your dopamine. So your dopamine can work on the hypothalamus to potentially decrease cravings, but it can also improve mood, and it can also improve ADHD symptoms. So a lot of adults with ADHD take this medication. It's combined with a medicine called Naltrexone, classically prescribed at like 50 milligrams or even more than that for things like alcoholism, or even for sometimes for like nicotine as well. But it's interesting because it's an antagonist at the mu opioid receptor, which is the opioid receptor that things like gluten and casein and kratom will bind to. So it can help with gut transit or even decrease gut inflammation. In addition, it's going to work on the brainstem, including the hypothalamus as well. So this combination is often used in people with food addiction or carb addiction or liquid calorie addiction, or people that eat a lot in the evening. There's not necessarily a perfect candidate for it, but it does come with a risk of, if someone has had a seizure before, it can precipitate seizures more likely. So it lowers the threshold of having a seizure.
What about feedback loops when you come off of this stuff?
Not as worrisome as coming off GLP-1s.
Really?
Yeah, not as worrisome. One of the interesting things about low-dose naltrexone compared to, I guess, high-dose naltrexone is low dose in general is between about 0.5 and 8 or maybe 12 milligrams, is that other inputs can supersede it more easily. For example, if you break your leg and you go into the ER, if you need some morphine, then it's not going to interact with that as much. And then it's also going to not like overly sensitize the receptor. So opioid receptors, dopamine receptors, and GABA receptors are classic for being sensitized or desensitized very quickly. But at lower doses, it is not as concerning. That being said, all medications and even, I would say all supplements, all efficacious supplements that can aid for fat loss are going to have a slight withdrawal rebound risk.
Interesting. So, but I mean, in that point though, if they can be sensitized easily too, then as long as you can maintain good lifestyle for a relatively short period of time, I don't know how long that would be, but it sounds like you can bounce back if you can just keep it under control for a while.
Yes.
Yeah. Is it tough to give an adequate time frame? Like if someone were to go on these compounds and come off, how long would they have to be grinning and bearing it, so to speak, until things are starting to come back to normal?
Probably 2 months of very close monitoring for most of these compounds, and probably 6 months for a GLP-1, especially if you try to come off without weaning the dose down first.
Okay. All right. And moving into number 5. What's number 5?
We can talk about Phentermine for number 5.
Okay.
There's a couple combos. You mentioned topiramate. There's a combination of like a low dose Phentermine plus topiramate, and actually there's a combo of Phentermine and the previous two that we talked about as well. And there's a lot of other ones in clinical trials that I think will be in the top 5, but they just haven't come yet. We mentioned amylin analogs in another one. There's triple reuptake inhibitors that are in the pipeline. So the future of obesity medicines is very promising, even better than these. But Phentermine has been used for a long time. It's a stimulant. So some people use it, again, in cases kind of like ADHD or hypersomnolence or narcolepsy. It gives you that like adrenergic, adrenaline type feeling, and also brings some of the like desire of not wanting to eat. In this same class, we can mention Vyvanse, which does now have an indication for binge eating disorder. Vyvanse is lisdexamfetamine, so just the dextro or right-handed amphetamine molecule from Adderall, but in a very slow release over time. It takes a long time to cleave off the lysine amino acid. So that's pretty similar to Phentermine. The downside of Phentermine is it has risks like palpitations, or even like, if you're prone to AFib, then you get AFib more often. But after you've been on it for a few months, especially if it's higher dose Phentermine, there is a pretty significant chance of rebound quickly. So in most cases, if you give someone Phentermine, especially at the classically high dose, and then take them off, they will regain all the weight. Now, how much of that is just because you only gave them 3 months to learn the lifestyle interventions, to like learn the diet and exercise and sleep habits that will give them solid ground where they're not sinking in quicksand? Probably a significant amount, but for that reason it's not used very often. The benefit that I think we mentioned previously about topiramate is that it can make carbonated beverages taste terrible. So if you're someone that just drinks like 20 classic, full sugar Cokes a day, then that can make a huge difference putting you into a caloric deficit.
Interesting. Now, anything kind of stimulant related, when people come off of this, do they deal with depression, are those common side effects when people come off of these?
They are. With Phentermine, it is usually not as significant of a withdrawal syndrome as for something like Adderall.
Okay.
For Vyvanse, you have a prolonged withdrawal syndrome, but it is not as severe because it's kind of a slower half-life. But yes, there's certainly withdrawal syndromes, but it's that way for most medications as well.
Yeah,
so,
it's that way with almost anything too.
Yeah.
It's that way with exercise. If you get addicted to exercise and you stop doing it, you have withdrawal too. So, it's like, I guess you just have to sort of substitute one addiction with another, for lack of a better way of saying it.
Yeah.
So are most of these things, like almost all we talked about, as you're seeing in practice now, they're being used for what? Maybe somewhere for 3 to 12 months, or are people intending on staying on them for a long time? What's kind of the goal?
A good rule of thumb is target weight loss per month of maybe 8 pounds. So depending on how much, and of course if an individual has a body fat of 60% and another one has a body fat of 35%, the 60% you would expect a faster weight loss. But just for like an estimate, let's say that you're losing 8 pounds a month and there's 80 pounds to lose, so that's around 10 to 12 months, and then 3 to 6 months of monitoring after.
Gotcha. I think that's perfectly reasonable. And we're going to do another video, which I encourage you guys to watch, talking about, once weight is lost, how to keep it off, how to maintain a higher metabolic rate. And I think that's kind of the next natural evolution of this discussion. So, Kyle, where can everyone find you?
They can find me on Instagram and a lot of other platforms at Gillett Health. On Instagram, it's Kyle Gillett, MD.
Well, as always, keep it locked in here on the channel. Cool.
Thank you.
Awkward handshake. Go.